so much for that kind introduction, and thanks to DGHI for inviting me here today. I work directly across the street, so it's always nice to have a short trip to come and visit. I'm excited to talk about this work for a lot of reasons, and many of them you just hit on. The significance of this work is really understated and under-recognized, so really important. There's a growing group of us here at Duke really interested in stroke, not just here locally, but also globally, and so I'll link those initiatives together by the end of this 40-ish minutes so that we can have some time to talk and discuss some of your interests as well. So I'm going to cover three major areas in the next 45 minutes. First, I want to talk about chronic diseases from a broader perspective as we had just started that discussion. Then some of you may not be aware, and others may have more information even than I, about the China Rural Health Initiative and DGHI's work with that, and how that really laid the foundation for the work that we're now doing in stroke and stroke recovery. So let's start first with chronic diseases. This is one of my favorite graphs from the World Health Statistics for several reasons. One, because without even reading anything other than the horizontal axis, we see that there's just a tremendous disparity between high, middle, and low-income countries in causes of death. Just tremendous. But then for the focus of this discussion, the bars that may look in different colors as we look at our different screens, but the ones that I've kind of capped here in the middle are non-communicable diseases, other NCDs, cancers in the middle, and cardiovascular disease. What you see, particularly for the low-income countries, is as time progresses, these are becoming larger and larger problems. And in middle-income countries, they started as big problems and only continue to get worse as time passes. And particularly with cardiovascular disease, it's interesting that you make that comment about HIV, but we already know China now is a middle-income country. This is a significant issue and just not receiving the attention that it really deserves. So when we talk more specifically about China, the disparities even within the country around talking about the disease between urban and rural China. On your left, for describing causes of death for cardiovascular disease, inclusive of heart disease and stroke, we see that stroke and heart disease contribute about 40%, or make up about 40%. But then when we shift our focus to rural, you see that stroke is even more problematic. And how do we really understand some of those issues and leading to higher rates of death in rural China? And I think you hit on some of those already. But then how can we better address them? Now, mortality is a really important endpoint, but what I want to shift our focus to are how we can keep people alive, living, and have a better quality of life. DALYs is a measure of disability-adjusted life years lost. And I like this map for several reasons, much like the World Health Statistics. Immediately apparent, people usually find either where they work, where they know people, or where they live. So here we are in the United States. Here, and the way it looks, at least by shading, we have the least problem compared to the rest of the world in disability-adjusted life years lost due to stroke. Okay? However, when we talk about the burden of stroke in the United States, we know that stroke is the leading cause of disability in this country for adults. So it's the leading cause of disability in the US, and yet it's much less problematic in terms of disability-adjusted life years lost in comparison to other areas of the world. And so the work that we're doing here in China, the work that we're doing in Canada and in the US, can easily be disseminated in many countries, and the questions that we're asking, the models that we're testing, are likely applicable or at least adaptable to other areas. And that's where we've been able to begin to bridge some of the work that we're doing across research teams to say, what are you learning where you are, and what are you finding, and how can we better translate that in other areas? So these are some of the points that you had capped already in your introduction. Thank you for doing that. Issues of underinsurance, limited healthcare facilities, lack of equipment, minimal training and expertise, particularly related to rehabilitation. So when we talk about disability, do we have healthcare professionals that can actually address impairment, so people's limitations in their ability to speak, their ability to swallow, take care of themselves, self-care activities, how you get dressed in the morning, can you walk? If you can't walk, do you even have assistive devices available to you? Are you now limited to your home? Do we have training of healthcare providers, of our family members on how to manage chronic disease? Secondary prevention is really important. And how is that being handled, particularly in rural China, as people leave the hospital from a new event? This is entirely new. They just had a major insult to their brain. And who's going to help them with these issues? So we have questions from the family. How is the patient going to manage? And do we have the expertise in the communities and in our the different healthcare services to be able to support managing this? And then we're facing, of course, scarce resources across the board. So even when we have the resources, do we have the expertise? But in many of these places, we don't have the resources to begin with. So what I want to transition to is this translational network that DGHI was a great part of, because in 2009, Dr. Merson and Professor Wu were funded by NHLBI and the United Health Group as one of 11, I think, centers of excellence to address chronic disease. What was really important in the partnership that they had formed between a developing and a developed nation was that they engaged many partners in China to be able to discuss how do we better address chronic disease. And through this work, they launched the China Rural Health Initiative. So the China Rural Health Initiative focused on 5 provinces in China. I won't try to pronounce them because there are others in the room who will do much better than I. In these 5 provinces, they addressed 120 rural villages from 120 townships and 10 counties. What was really important was the work that they structured across these partnerships in these 5 provinces led to several pragmatic clinical trials. So these were clinical trials in real-world practice, trying to best use the resources that were available and build capacity to be able to do research and improve both healthcare and outcomes for the people that live there, primarily focused around issues of primary prevention for cardiovascular disease. This work is now coming to an end. So this was funded in 2009, ending now in 2014. And what was really interesting as I came to Duke in 2010, it was early on in the China Rural Health Initiative, beginning to ask those questions of, okay, well, you're addressing hypertension, you're addressing diabetes, you're addressing people at risk for heart attacks. What about stroke? Where does that fit into this network? We began these discussions, and I was really fortunate to be introduced to the leadership at the George Institute to be able to move some of those discussions forward so that we can begin conceptualizing what models of care would be to support individuals that would have a stroke in these rural regions. So that's where I'd like to focus the rest of my talk on how we got to the RECOVER trial. There were gaps identified by observation from people that had been involved in the China Rural Health Initiative, provider and patient reports, research that had been done in China and in other countries as well, both developed and developing nations, that there were significant gaps in a lot of places. And where do you start when there are that many issues? From a health systems perspective, we recognize that when someone has a new stroke and they're in the hospital, in China or elsewhere, there are specific patient needs that we need to be addressing. And recognizing early that in rural China, many of these patient needs already weren't being met. There's a evidence base around discharge planning. If someone's leaving the hospital, what do we need to teach them? How do we need to work with their families? How do we prepare them to go home? Because there aren't going to be services for many of these people after they leave the hospital. So how do we prepare them to go home so that they can live the best lives that they can and be continuing to recover? Hospital discharge planning, a really weak area, particularly in these facilities in rural China. The rehabilitation expertise to support particular physical functioning, cognitive functioning, social functioning was non-existent. There isn't. The concept of rehabilitation in most of rural China is let's support them to get up and walk when they're medically stable, potentially months later. Bed rest is favored. Doing the activities for family members that have had a stroke is encouraged still in many areas. So the evidence base around rehabilitation and supporting improved self-care and mobility hasn't yet translated to these healthcare providers, a significant gap, and where we were recognizing, okay, we know that there are opportunities here, but all of these are significant issues, and how are we addressing healthcare for stroke patients? So now these individuals who have had a stroke go home. New issues arise. We now have new patient needs in the community, new questions. How do we live in the home that we've had? You know, I may not have the use of my arm, I may not be walking, I may not be able to feel my leg, I may not be able to speak to you anymore, I may have lost the ability to communicate. How am I dealing with my family? So there are new caregiver needs. Depression post-stroke is very common, as you can imagine, living with these new impairments. Also, gaps around community-based care. Do the providers understand what is needed to newly care for these individuals that have impairments and are at significant risk for complications after a stroke? And again, we have no expertise in the community around rehabilitation and promoting physical, cognitive, and social functioning. Significant gaps. Gaps in the hospital, gaps in the community, and then we have the gap of getting them from the hospital to their home. In the United States, Canada, and some other developed nations, the UK, Australia, many of us are kind of folding this under an umbrella right now titled transitional care. This idea of transitional care is to develop almost a short-term support mechanism for how we get people from the hospital to home. It's an intervention in and of itself. In this country, we're actually resourcing nurses, physicians' assistants as transitional care leaders, coaches. There are a lot of titles for them. It's reimbursed now in the United States. In Canada, it's a standard of practice. So there was an opportunity to think about, we could do this better, but how when we don't have the resources in the hospital or the community? And how are we supporting this tremendous gap? Transitional care is a set of actions, and this was defined by the work done primarily in the United States, a set of actions designed to ensure coordination and continuity. When we asked that question in China, though, it was coordination for who? Who are we coordinating care for? Between the hospital and, okay, well then we thought we have village doctors we can begin to work with, family members, support systems, social networks in the community. How do we work on coordination? Because it's really addressing just that transition, the transfer across two settings. Why is this important? Because we know from years now of developing literature that poorly executed transitions, discontinuous healthcare, increases the risk for medical errors, medication errors, poor patient outcomes, stress on caregivers and family, and unnecessary or inappropriate service utilization. Often issues that come up for adults that go home could have been prevented, and many of these issues could have been addressed with preparation and some support early on after families go home. We looked at, so the Centers for Disease Control in this country commissioned a systematic review of transitional care for stroke. Fortunately, we won that contract here from Duke, and what was really interesting in looking at these models is that ultimately for stroke, we had the strongest literature around a pre-existing model not related to transitional care, but actually related to rehabilitation. The Cochrane Review is actually developed and published, updated quite frequently now, by the Early Supported Discharge Trialists, and that's the name of the model, Early Supported Discharge. What's interesting about early supported discharge is the whole intent, developed out of tested in the Netherlands and in Scotland and the UK, is to get people home sooner with a team of people to support them to go home, start that rehabilitation in the home, make sure the family is ready to take care of this person collectively as a unit, and then get them connected to services in the community. But I just addressed that all of these are gaps in rural China, right? We don't have the ability to get people out of the hospital early, to have a team of people supporting them to go home. Nobody has trained the caregivers to take care of them. Who are we connecting them to for follow-up care? So all of these, we thought this is a great model, early supported discharge, standard of care in many countries, not this one actually, but many other countries, with great opportunity and strong evidence behind it. How can we think about this in poorly resourced areas or rural areas without the resources available? The model that we had used when we were doing the systematic review for transitional care came out of the National Quality Forum. This was actually similarly proposed for heart attack and for hip fracture. We adapted it for stroke. And what you'll see here is that you have your population at risk, they have an acute event, they go into the hospital, and in developed nations, they move on to receive post-acute care and rehabilitation, and then are fortunate enough to continue living in the community or are living in, move on to live in a nursing home or long-term care. Well, as we began these discussions in 2011 with the George Institute and others in other nations, we thought, just as we finished the systematic review and published it, that model doesn't fit. It doesn't apply in rural areas and areas that don't have rehabilitation available. Post-acute care isn't there. So not quite a global perspective. Of course, we learned that after the systematic review was published. And so as we talk about the applications of those findings, how important it is to think about how we would do this work in other countries. All of the studies that we had included in the systematic review and all of the studies that the Cochrane review had included were all from developed nations. So what would we then determine would be appropriate for rural China? Initially, we were hoping that we could look at the early supported discharge model and adapt it in a way that would be appropriate in rural China, working with the China Rural Health Initiative communities, and we just didn't have the resources available to be able to do that as an implementation project. And so out from these discussions came the RECOVER trial, a randomized control trial, I love how acronyms come together, don't you, on rehabilitation through caregiver-delivered, nurse-organized service programs for disabled stroke patients in rural China. I have to read it because I won't remember that whole thing. But the focus here is that it's nurse-organized. So we know we have nurses that are capable in the hospital. They may not have the time yet available, but they are capable to assume a primary role in preparing families to go home. But then ultimately, when these families go home, it's ultimately the family unit, the caregivers and the person who had the stroke together that will really need to take on the bulk of the responsibility in managing and preventing complications and continuing their rehabilitation. And our focus is in rural China. So aptly named the RECOVER trial. So RECOVER is a collaboration of a subset of partners from the China Rural Health Initiative, organized and being led still out of the George Health Institute. We had submitted an initial proposal for funding in 2012, I think it was, and were unsuccessful, but we were determined and submitted another one, potentially another one after that. And ultimately, we did receive funding from the China Medical Board to pilot the intervention that we're working on right now. The PI is out of the China Medical University, and it was really fascinating. We just all together came together as a study team early in March, and to have everybody together after having written for now a year and a half on how this might happen, and then actually discuss how it will happen, was a monumental experience to really be able to put paper into action and be able to talk through how that was going to work from our university partners, the George Institute in Australia. I was representing here from DJHI from Duke, representing transitional care, geriatrics from the George Institute in Australia, and rehabilitation from the University of Oxford. Our partners from the universities and medical centers in China really taking the lead both on helping us understand from an implementation perspective how this would happen, leadership, being able to engage physician leadership, hospital leadership, connecting with the communities, and also being able to talk about resourcing. How are these decisions made? How would we be able to empower nurses when a lot of the care being delivered in these rural hospitals is physician-led? So this was our team. We spent 3 intensive days together. It was my first time in simultaneous translation, and I can say I'm a better person for it. I can now listen out of both ears in different languages and follow a discussion. Really fantastic. The first full day we spent just talking about the intervention and really coming together on where the evidence is, where are the opportunities, what's been developed, and how can we best leverage where we wanted to go. Our second day focused solely on data collection and how can we best do that, decreasing the burden, maximizing the use of standardized and validated tools. A really great discussion. And the third day on evaluation our group dwindled over time. It was fantastic to get together, and for whenever we do this again, we were able to come to an understanding across countries, across languages, and across conceptualizations of how we thought this was going to work. What was really instrumental is, you see the fellow here in the middle, Richard Lindley, a geriatrician from Australia, at the George Institute in Australia. He's leading a similar trial right now in India called the ATTENDS trial. So where they had just, I think that week, enrolled their first patient. They're far enough ahead that we were able to learn from some of his lessons learned. I'm also implementing this work right now in the United States, so I was able to talk through some of the issues we had specific to data collection and getting people on the same board across sites. So it was really helpful to talk about some of the lessons learned of work that was ongoing, and then talk about how would this really translate to these rural provinces, and I'll tell you which one. So the goal of the RECOVER trial is to develop, so it hadn't been developed, it was conceptualized, but to develop and then implement and test this caregiver-delivered and nurse-facilitated discharge planning and rehabilitation service model. And as I mentioned, we were originally hoping it was an early supported discharge model, but we're now recognizing it's definitely a component of discharge planning and then continued rehabilitation in the home. The focus primarily on function and health, and again, among disabled stroke patients. So I'll talk about inclusion criteria just briefly in a couple slides. I want to walk you through the intervention because as I was talking about some of the gaps, we've had to think more about how this would really happen, not just where we're testing, but from a sustainability perspective, how would we roll this out further? I mentioned the focus here is on the nurse. So from where I sit in the School of Nursing, and I'm not a nurse, it was really interesting to understand the differences of nursing across countries. So I've been back and forth meeting with the schools of nursing in China and comparing some of their programs with ours, and it's really interesting to understand the level of knowledge and training, particularly for new nurses in acute care in China. We made the determination that we ultimately needed more experienced nurses to take on this role. And so, focusing on nurses in the county hospitals, we're going to need to work with the lead nurse manager to identify the most appropriate nurses to take this on, because it's not going to be appropriate for a new nurse directly out of school because of some of the critical thinking that you'll hear in a minute that's needed. We're relying on physician, nurse, and therapist developed training modules and ongoing mentorship from our Beijing-based partners and also from the lead county hospitals to support the nurses. The nurses are going to go through training, in-person training, and I'll talk about that and what components, but we felt it was really important that they have someone to connect back to, review cases with, ask questions if they need to, and we're going to do periodic updates with them, particularly during the implementation phases, so that as things arise, we can address, maybe you needed more information on this, maybe you needed more specific training. Oh, every patient's different, maybe it was something we actually didn't cover. But the training, so this arrow right now represents it's one way, but we are trying to work on how this would be a two-way communication so that they aren't just trained and then left with, okay, this is where I am until the next phase of review. The intervention itself, so the nurses will actually do the screening, identify the patients, and then after consent and enrollment, and I'll show you where that falls in the outline, the focus during the hospital phase will be to teach the patient and their family about stroke, about recovery, how to identify if something problematic is happening after they go home, what management is expected. And then the training focus is really around task-specific things that are common to their day. So you think about what you do when you wake up in the morning. You get up, whatever order this is for you, you get up, you get dressed, we eat, we brush our teeth, we leave the house. Most of us leave the house every day. And how do we support these families to now do this with someone who has had a stroke? And you think they may be cognitively impaired, they may be speech impaired, they may have physical impairments, they may be able to use their limbs but not feel it. There could be more than one issue together. And so this in-hospital focus is really on teaching and training. We brought in the concepts of teach back so that we are teaching and we have them teaching it back to the nurse. Importantly, here is a discussion about joint goal setting. We don't want to set someone up on a developmental program in an area that isn't important to them. So an example that I joked with them during this last meeting, I had a patient who was a saxophone player. And he didn't care if he did anything else. He wanted to play the saxophone when, within a year after his stroke. So he wanted to do away with everything else, but find a way to teach him to play his saxophone with one hand. Similarly, I had, and maybe many of us can relate to this, I had a fellow who was an avid, he liked to drink wine. And if anything else, he wanted to be able to use a wine opener. Like, this was his goal after his stroke. And it was really a focus on his rehabilitation program around fine motor tasks, being able to do those things. And when you talk about what is important to a person for when they go home, it's really being able to customize their learning and their training around what they're going to be doing. It's one of the physicians in the meetings had said, because of a question that's on an instrument, something about doing laundry. He's like, I've never done laundry. I said, fair enough. And we probably don't need to be teaching some of these patients to do laundry just to be able to meet this question on the questionnaire. So really being able to understand what is life like for these patients and their families. And that's why this joint goal setting becomes so important. And this is why it becomes so important that the nurses have some experience already in working with patients to really be able to have those discussions and be able to guide the care planning that way. Discharge planning, as I mentioned, is actually has an evidence base around it, and we know that this isn't happening right now in these hospitals, and so we're working with them to structure an evidence-based discharge planning protocol. The intervention then continues after these families go home. And so we know from the work in this country and others that it becomes really important to continue to connect with patients and their families after they go home to, if nothing else, answer questions. But often to then facilitate, okay, you've addressed this, you've made this transition, what is it next that you're next going to be facing, whether it's I haven't yet left the house, or I'm not yet eating solid foods, for example. Many stroke patients have swallowing difficulties, and to be able to essentially move people through different stages of their recovery. So calls or visits are going to happen at 2, 4, 6, and 8 weeks after hospital discharge, and then the intervention ends at 2 months. We're going to start blinded outcome measurement at 3 months, and then at 6 months, so 3 months on the phone, 6 months in person, and then if resources permit, we'll do a 12-month follow-up as well. The control group will be conventional care, which we know right now is essentially you're discharged, and you're discharged. See you later. But we will continue to follow up with those patients as well, but they won't be receiving the 2, 4, 6, and 8-week telephone calls. Our primary hypothesis is around physical function, and so because of that, our nurse training will also focus on 3 primary domains. It'll be mobility, self-care, and why the third isn't coming to me, I'm not quite sure. Oh, bowel and bladder incontinence. So those would be the 3 areas that we'll be training the nurses on in a train-the-trainer type model. We quickly realized that while we wanted to focus training on those core areas, we needed to actually back that up a little bit and actually provide advanced stroke training as well. Because these nurses are essentially generalists working across a lot of different conditions with a lot of different issues. And so we'll be providing neuro training specific to stroke first, teaching I should say, and then training in the areas that they would then be training caregivers and patients in. Secondarily, we'll be focusing on physical functioning, and you can see the instruments that we'll be using, quality of life, a global measure of disability and depression. And then we're going to explore, and we're still having discussions of how to best measure and address the burden on caregivers. Some of that discussion is around consenting the caregivers. Would we work with a patient who doesn't have a stable caregiver? Sometimes people go home with one person for a month. Those family members return back to work and somebody else comes in, so now we don't have a consistent caregiver, but if we consented one, do we reconsent someone later? So we're still trying to work out how to best measure outcomes related to caregivers. We're going to measure rehospitalizations and other healthcare utilization the best we can, and that's why these are exploratory and costs related to their hospital stay. Out of the 5 provinces from the China Rural Health Initiative, and Dr. Merson, thanks for joining. If people have questions, we can direct questions hopefully to Dr. Merson about the China Rural Health Initiative. We're focusing on 2 and have chosen 2 hospitals within 2 of the provinces as our primary sites for this RCT. Our initial focus, we will start this summer to test first just the training protocol with patients, and then we will move to a pilot test with 20 intervention patients and 20 controls, still randomized in each of the sites, and then we'll move to 100 and 100 for each of the hospitals. There were some questions of whether we should do this as a site-based randomization or patient randomization, and on a patient level, then how would we then, we talked a lot about the issue of contamination. So if we're teaching a patient and their family, well, isn't there another patient and their family likely in the room who'd had a stroke as well? So we've got buy-in from the hospitals that we will actually have the training for those in the intervention group in a different room or somewhere else in the hospital. So that was a commitment that we then will have to think about if we translate this to other hospitals across other areas. Will they be able to make that same commitment if we were to expand and do a larger RCT? Our inclusion criteria, there's a lot on here, but our primary point that I wanted to focus on here is this issue of residual disability. The work in transitional care and the evidence in early supported discharge showed that the outcomes were strongest for those with mild to moderate disability. We're not going to have a lower limit. If people are severely impaired but still expected to survive 6 months, for example, that they're not, we have here no evidence of widespread cancer, indications for that they would need palliative care by westernized standards, then we're going to include them. But on the higher end, this Barthel index goes to a score of 100, scored on intervals of 5. So anybody over a score of 80, we're actually not going to include at this time, particularly because of our focus on functioning. The Barthel index is a measure of activities of daily living. So if someone has a score of 85, they're functioning pretty well, at least in the home. But again, as I mentioned, we debated at some time around exclusion criteria and ultimately decided that we would exclude a patient if they were unable to identify a suitable family-nominated caregiver for training, at least within the hospital, to know that somebody else was there to take in and retain this information. We were discussing this at a stroke support group actually here in the United States, and a very functioning stroke survivor had said to me on the way out of this meeting, she said, "I don't know why they give so much information right before hospital discharge." And I said, well, you know, often they're thinking this is the last time they're going to see you, like here's your binder, here's your information, here are all the people you can call. She goes, "I just had an insult to my brain. Why are you giving me so much information before I leave the hospital?" And she had a great point. I mean, a stroke is a brain attack, and yet we're loading all this information, and it just strengthened the need to really be sure that we had someone else with the patient in this trial to be taking this information and be trained prior to hospital discharge. So this is our implementation plan, at least how we see it right now. We're in the process of developing the protocols for training and training manuals and the content for those, specifically targeting first the nurses, and then we'll work on the protocols for working with patients. Ideally pre-testing in August, so I'll be going back in June hopefully to visit at least one of the 2 villages to better understand the capacity and how this is going to work. The pre-test in August, a pilot starting in September with 20 patients, as I mentioned, and then we're hoping that of course these are all timed around holidays. I'm getting very good with the calendar in China, and that we will not start the trial until after Spring Festival in March. And that was really important, so ensuring that we would have follow-up appropriately completed within those parameters. We had also promised to the China Medical Board that in addition to better understanding how we would do this work, that we would actually have products come out of this that would potentially be important. One would be a rehabilitation guidebook for caregivers. And what was interesting is when I mentioned this back to the American Heart Association in this country, we don't have that here. We have 50% of the patients in the United States go home without services, and we don't give them any information at all about continued rehabilitation. And that's what Google's for, is what I heard from one provider. So you think about the opportunity that we could extend this work even in the United States is huge. And many of the physiatrists have since said in the months since we started talking about this work in the ATTENDS trial that we could do so much better here in supporting stroke patients who go home without continued services. Because likely, we originally thought likely, now we know they're at 50% higher risk for coming back within 3 months, these people that are going home without services. And we could be doing so much more in teaching about preventing complications and continued rehab. So this work that we're doing in China has global impact and could be used right here at home. The nurse training manual, very interesting. So we've had a discussion with several of the schools of nursing in China. So this has been strongly supported, of course, by my dean and the work that I'm doing across the street. And I guess it's 2 weeks ago now, we had a US-China forum here on campus. And to be able to talk more about how we would disseminate this work and how we would support and build capacity for rehabilitation nursing in China and in other countries. We had the past president of the Association for Rehabilitation Nurses attend the meeting to talk about how we could be using resources that already exist. We shouldn't recreate the wheel if it's already available. So how could we determine whether it's applicable in other countries, and we're evaluating that right now. And then a booklet kind of pulling all of this work together. Of course, the study report to CMB, we definitely want to focus a policy brief to the government, focus as we were talking about the importance of disability and addressing disability, aging, and prevention of cardiovascular disease right now are all important topics. And we will, of course, be needing to disseminate the findings from this work. So that's the Recover trial as it is right now. So it's the end of March. And as I mentioned, I was only there 3 weeks ago. What's been really exciting is the energy behind this team and the energy about wanting to continue to invest in this work and continue to look for opportunities of how we could grow. And so we were there in, I guess it was October, for a Center of Excellence meeting, and as we started to talk about all of the work that was being done with the China Rural Health Initiative, how can we integrate the lessons from those different studies and the ideas of others around the table to really move this forward, not just for stroke, but for other chronic conditions, particularly those that have an acute event and end up in the hospital. And again, there are these themes that we could be addressing: inpatient discharge planning, preparing people to better to go home, home-based care. There's so much work that we could be doing around supporting care in the home, as we were talking most recently of just being able to support living a better quality of life and prevention of functional decline, and the community-based care. 3 huge areas, and from a system perspective, how do we connect those? So I had proposed to the group in October at the Center of Excellence meeting that we could pool what we know so far and better understand what would be appropriate in a kind of a collective model from transitional care, from early supported discharge, and from telehealth to think about kind of the next version of the Recover trial. So as I called it, Recover Trial 2.0. And it got to be a really massive protocol, which of course can be quite scary without a lot of funding, because it would essentially entail a multi-component intervention addressing discharge planning, family-led therapeutic activities, follow-up with these families, the transition to community-based care. Who are we connecting these families to? And there was some work in the China Rural Health Initiative with village doctors, ongoing medication management, better understanding the formularies that are available for medications, and then the prevention of complications. So it is a very big systems perspective on how we would better address care from hospital to home, but definitely work that needs to be done. We know from work in this country and in other developed nations that while we know these multi-component interventions work, we actually don't know which strategy within these multiple component interventions works best. We don't really have the evidence. These studies aren't powered to say that discharge planning is, if we had to invest all of our effort into one component, which would it be? We don't know which it is because they test them collectively as multi-component strategies, and we're limited in our knowledge at this point. A trial that's currently under review, I guess that we should be hearing soon on. So this is how we met. We were really pleased to meet over email in the development of a technology-supported decision support intervention. So you think about what we're doing with Recover. and then moving the components that we could to a technology-based intervention. So nurses and physicians at the bedside in the hospital would have clinical tools and decision support aids and guidance to be working with patients. And then the village doctors for follow-up would have similar tools available to them on a tablet or something to be able to support management in the community. And so this was a technology-supported intervention for the providers. And then we had begun conceptualization on the iRegain trial, and this was from the patient and family perspective. So mHealth intervention, kind of you think about everybody collective in the system. So it breaks the Recover Trial 2.0 into a provider intervention, technology supported, and a family and caregiver intervention. And trying to understand the feasibility of these is going to be a task and study in and of itself. The Duke Clinical Research Institute is currently pursuing and soon to be solidifying a partnership with the leadership of CNSR, that's the China National Stroke Registry. And I'd like to be working with them, I really hope to be working with them, to better understand the network of hospitals that they have in the China National Stroke Registry. It's 220 hospitals, and can we work with them to begin addressing these issues of transition and rehabilitation and scalability out to that network. A huge opportunity. The leadership of this group already has a network for clinical trials and is managing several, so they definitely have the capacity. What will be interesting is, do they have the interest? As we started the discussion, the interest around stroke and recovery really doesn't get the attention it could or should. Many of these areas we talked about, other opportunities of how we could test. We talk about these all the time, and as funding comes up, I think it's always in development. Whether we focus on caregiver engagement, whether we focus on the community workers, whether we focus on persons with cognitive impairment, there are a lot of different ways we can focus the interventions, but ultimately when we think from a system, we had to think of what would be our ideal, and then how do we begin to test the different components and build those out. This is a little fuzzy, but when I had started this work, I don't know, 10-something years ago, I was taking pictures of all the Mind the Gap signs around the world wherever I'd go, because for me, this is the reminder of whenever I see these, of what we are doing to our patients when they leave the hospital. They walk out of the hospital, they step off the curb, and that's it. And nobody's telling them to mind the gap. It's a huge gap when they leave the hospital, what that's like. And so this was actually the one out of the train in the Beijing airport that you have to take in the terminal. And you had to see the people staring at me while I got really close to try to take this picture, but I didn't have one from China yet. But as a reminder, as a symbol, when you see these, the mind the gap, that transition is such a harsh one for people that aren't prepared, and the opportunity is huge to better address it. To improve the lives of stroke survivors, to reduce the burden on caregivers, improve evidence-based care, because we have it, and how do we best adapt it to areas, and to improve the quality of care. Just great opportunities, and I'm really excited to be working in this area. I'd like to thank, so my husband came here today in part because he supports me on these trips and lets me leave for weeks at a time. But really, I wouldn't be able to do this if I didn't have my family support, so I am so thankful. As I mentioned, my first 2 trips to China were supported by the Duke University School of Nursing, and then I was fortunate to travel with my colleagues from the DCRI, who have now become dear friends, and Ying is here as well, and to continue this work and think about what are our opportunities across medicine and nursing, and how can we better collaborate from an interdisciplinary perspective. We have faculty in social policy and in psychology, and we need to be doing this in all countries, interdisciplinary work. Many of you know Professor Wu. She's also faculty in the School of Nursing and not a nurse. This is why I love this picture. I'm faculty in the School of Nursing and not a nurse in my areas in care coordination. Isaac Lipkiss is faculty in the School of Nursing, not a nurse. He's focused in cancer. And this is our dean, who supports us in doing this work around the world, which is just fantastic. So I'm very thankful to both groups, and now to the DGHI for supporting this work as well. And to my new friend and collaborator, Li Jingyang, who's at the George Institute. And I was noting at the beginning of this presentation, every time I go to China, I see blue sky. So when people talk about pollution, I've been very fortunate to have some great weather on my trips, and have seen some really wonderful things. So thanks for having me, and I will happily discuss this further or answer any questions if you have them. Thank you.